Hello, good evening, and welcome to the International Dermatology Education Foundation Educational Series and Webinar. My name is Dr. Ali Shabazz. I am a double board certified dermatologist and a clinical assistant professor at the Texas A&M School of Medicine, and I practice here in Austin, Texas. It is my privilege and honor to be introducing Dr. Julie Harper, who is a board certified dermatologist here at the Dermatology and Skin Center of Birmingham. She's also the founding director of the American Acne and Rosacea Society. She practices in Birmingham, Alabama. Today we'll be discussing a single prescription for triple combination topical acne treatment. As always, we would like to start off by thanking our sponsors, Ortho Dermatologics, for this wonderful webinar and educational series. Before we begin, just some logistical points. If you are having issues hearing the webinar, you can listen to the presentation using your telephone. Just please select phone, call in the audio pane, and the dial information will be displayed. If you are having technical issues, please submit your questions in the question pane on the right-hand side of your screen. At the end of the webinar, a survey will pop up in your browser and we will be emailed to you within 1 to 2 days. We would greatly appreciate if you could fill out the short survey. And within 1 to 2 days of the webinar, a certificate of attendance will be emailed to you. Questions, please submit your questions using the questions pane on the right-hand side of your screen. Please reserve questions will be answered at the end of the webinar by Dr. Harper. And as always, I'd like to thank my derm dad, Dr. Leon Kircik. He is a mentor and also the president of the International Dermatology Educational Foundation. He's a clinical professor of dermatology at Mount Sinai in New York, as well as a practicing physician in Louisville, Kentucky. The International Dermatology Education Foundation is a nonprofit organization whose principal mission is to raise awareness and improve the dermatological care all around the world through education, especially in underserved and rural areas. As you can see, we have the privilege of having some esteemed guests on our webinar series who are experts in all fields of dermatology. These webinar series are usually in the evenings and they will be live broadcasted, so please make sure that you are up to date with all information on the webinars through Instagram, Twitter, and Facebook. You can also visit our website at IDEF educationalseries.com to register for upcoming educational events. So without further ado, I would love to introduce Dr. Julie Harper. Thank you.
Thank you so much for the invitation, and thank you to everyone who is on the call tonight. We were both already commenting that it's, busy clinic days, and then to follow that up with some education in the evening, I really want to thank all of you for your time tonight. So there must be some good acne treaters who are on the call, and I'm excited to go through this deck with you. This is a product that I think we could say we waited a long time for this product. Many of us in the acne world for years and years had been excited about, really we would call it the Holy Grail. We said whoever can come up with a triple product, that's going to be the Holy Grail in acne. And I don't want to go so far as to say a Holy Grail, but this really is unique. We have the first and only FDA approved triple combination topical treatment for acne vulgaris in patients 12 years of age and older, and this is Cabtrio. So my name is Julie Harper, and again, it's a pleasure to be with you tonight. I'm a paid consultant to Ortho Dermatologics. They are the manufacturer and the distributor of Cabtrio. I'm also a contracted speaker for Ortho Dermatologics. So why would we get so excited? Why would we be thinking that having a triple would be the Holy Grail? And I think there's a couple of reasons for that. First of all, if you look at the guidelines from both 2016, but also from 2023, they both talk a lot about using multimodal mechanisms of action. And that's because when you think about the pathogenesis of acne, we know that we have several pillars that we have to target. So when the guidelines talk about using multimodal mechanisms of action, especially when it comes from the topicals, think about the products that we've been using. For years and years, we've had benzoyl peroxide. For years, we've had topical antibiotics. For years, we've had topical retinoids, but we haven't had them all together. So historically, we've been able to use those, but we've had to use them independently, or maybe at most we've had a double fixed dose, but we've never had all three of those active ingredients together in one product. So I think just mechanistically, we were very excited about this, but we're also excited about it just from a practicality standpoint. So what I do every day is what you do every day in clinic. I treat patients. And I really enjoy that, by the way, but it can be a challenge. And so I think most of us know it, and maybe not even just talking about our patients. Maybe if we turn the mirror around and think about what we do in our own lives, it can be difficult to be compliant when somebody has a complex regimen. And so, you know, have you ever had somebody where you give them 2 or 3 products and you have them come back to clinic and they have picked their favorite product and they're not using the other things that you even ask them to do? So another potential benefit of this is just compliance. Now, this particular chart is looking at what's called primary non-adherence. And so what we're talking about here, primary non-adherence, means I didn't even get the prescription filled. And so take a look at the table here. And what you'll see is when we write one prescription, people are pretty likely to get that filled. But when you go to 2 or more prescriptions, man, we really fall off the deep end here. We've got 30, almost 40% of people who, once you write 2 or more prescriptions, they're not even getting the prescription filled. So it's not even a matter of I get home and I forget to use it. The product never even comes home. So I think we're excited from a mechanistic standpoint, but we're also excited from a simplistic standpoint. But I want to go ahead and maybe I'm editorializing a little bit here. As we get into the data, and we're going to start with important safety information, but I think the most exciting thing about this drug for me from the beginning has truly been the efficacy results. And we're always going to talk about adverse events and safety as well, but I really want you to pay attention to the efficacy. So let's start. So again, this is CAB trio. So this is clindamycin, adapalene, and benzoyl peroxide. So 3 products, and you're going to start to even notice that there's something different about this, even on an important safety information slide. And that's because you're going to see some things on here that are related to the benzoyl peroxide. You're going to see some things on here related to the adapalene. You're going to see some things on here related to the clindamycin. So let's go through this. We only have 1.5 slides on this, but I think you'll learn something here. So first of all, do we have any contraindications? It's important that we know that when we're treating acne. So there are 2 potentially. One is known hypersensitivity to any of the ingredients or the constituents of this product. So if someone has a known hypersensitivity to clindamycin or adapalene or benzoyl peroxide or lincomycin, which you might remember, a lincosamide antibiotic that cross-reacts with clindamycin, then that would be a contraindication for the product. The other would be having a history of regional enteritis, ulcerative colitis, or antibiotic-associated colitis. And that, of course, is not specific to Cabtrio. That's all about the clindamycin that is in this product. So we've seen that with other products as well. Now, when we go to the warnings and precautions, the hypersensitivity piece there is really mostly about benzoyl peroxide. So hypersensitivity reactions, including anaphylaxis, angioedema, and urticaria have been reported. By the way, not in the Cabtrio studies, but have been reported with the use of some of these different components. And if that happens, of course, stop the drug and seek appropriate therapy immediately. The colitis here is about the clindamycin can cause severe colitis, which may result in death. This was also not reported in the clinical trials. But if somebody did develop diarrhea while on Cabtrio, then discontinue therapy. Photosensitivity is mostly about the adapalene and the retinoid, but could also be about the benzoyl peroxide. It may increase sensitivity to ultraviolet light, so we want to just warn our patients about that. Skin irritation and potential allergic contact dermatitis, I think really with just about any topical that we use, these are things that we'll talk about. Stinging, burning, and pain, erythema, dryness, irritation, exfoliation, and dermatitis may occur with the use of Cabtrio. And we'll get a chance to talk about that specifically in really both the phase 2 and the phase 3 trials. So we'll go through that. We know there are things that worsen the irritation. For example, weather extremes like wind or cold. And depending on the severity, patients can add a moisturizer. They could reduce the frequency of application, or they can stop the drug. We want to avoid applying this to broken skin or eczematous skin and avoid using waxing as a depilatory method when skin is being treated with Cabtrio. And then right before the bold print, use of Cabtreo with concomitant topical acne therapy has not been evaluated. So this is kind of a combo all in of itself, but when it comes to adding other products to this, that hasn't been studied yet. So incidentally, I won't be able to answer any questions about that either. Okay, so let's talk about adverse reactions. Again, we're going to talk about this when we get into the studies, but if you look, the most common adverse reactions, those that happened at a rate of more than 1% in the Cabtreo group and greater than the vehicle group, were all application site reactions like pain, erythema, dryness, irritation, exfoliation, and dermatitis. Now, perk up on this next one, okay? Drug interactions. Use Cabtreo with caution in patients receiving neuromuscular blocking agents. Now, what we're really talking about here is like a neuromuscular blocking agent that might be part of anesthesia, for example. And this was not reported with Cabtreo, but it has been reported with lincosamide antibiotics. Those lincosamide antibiotics can potentiate the effect of these neuromuscular blocking agents, making their effect last longer. And when I first saw this in the Cabtreo deck, I was like, oh, I don't believe I've ever seen that before. Well, I was wrong. This was also in the Icahn important safety information and the Onexton. So it's not new, but it's called out maybe a little bit more here. So if one of your patients were to read about that, that's really what we're talking about there. Okay, so let's talk a little bit more about this Cabtreo, these 3 active ingredients and their potential mechanism of action. You'll notice in the italics on a lot of this, it'll say like the precise mechanism of action is unknown, or the precise clinical significance is unknown. And I do want to call that out, but I think the ClinDef part is pretty straightforward. It's antibacterial. We're working against C. acnes here. So I think that one's pretty straightforward. Adapalene being our topical retinoid. We know what the retinoids do. They're anti-inflammatory. They also help to normalize follicular hyperkeratinization. They're normalizing cellular differentiation. And so, you know, what that exact mechanism is in acne, we'll still say that there. And then benzoyl peroxide, a very powerful oxidizing agent that kills bacteria by oxidizing them. There is no resistance to that. And so what that means is, let's say somebody's on clindamycin by itself. The clindamycin is killing the strains that are sensitive to it, but there are some that are resistant. And so you're just putting natural selection or selection pressure on that system, and the strains that are resistant get to take over. Well, because the benzoyl peroxide comes in and oxidizes and there's no resistance mechanism, it's going to kill the sensitive and the resistant, and it won't let a resistant strain take off. And so it's nice that these are in there together. We don't know precisely, again, the mechanism or the clinical significance of that, but that's our 3 main players that are in Cabtreo. And we all know, and I'll shout out to Leon Kircik, our fearless leader here at IDEF, but we know that vehicle is very important. And I said that cautiously for those of you who know what I'm talking about there. But Cabtreo, part of what's important here is this polymeric mesh technology that these active ingredients sit in. So the clindamycin is dissolved, the benzoyl peroxide and the adapalene are micronized. More than 90% of them are less than 10 microns. They are also suspended throughout this polymeric honeycomb mesh technology. So it keeps them dispersed on the skin and just helps with more even release of the drug. And so we have this polymeric mesh technology. We have these 3 active ingredients, and then 85 to 90% of the rest of this vehicle is water. Look at the bottom left. There's not a super long list here. We have purified water. We have carbomer homopolymer as a gelling agent, propylene glycol as a humectant, and potassium hydroxide as an alkalizing agent. And then look at the title of this slide. I just told you everything that's in it. What isn't in it is preservatives or surfactants or alcohol or occlusive agents. So this is a well-designed product for our patients who have acne. And speaking of acne, let's move on now and talk about some clinical studies. So we're going to look tonight at the phase 2 and the phase 3 studies. And I don't think it's very often that we spend much time on the phase 2s, but the phase 2s were, for lack of a better word, when they came out, they were kind of shocking. And I'll show you why as we go through this. So we'll look at phase 2 first, and then we'll look at phase 3. So the phase 2 studies, These are going to be, this is multi-center, randomized, double-blind, parallel group, vehicle-controlled studies, and they enrolled down to the age of 9. Now, you already noticed on, I think, the very first slide, we said this is FDA approved down to the age of 12. So you'll see 9 come up a couple of times, but there were not enough people between 10 and 12 years of age, so the FDA approved this down to 12. But you will see the number 9 in here several times. We're going to enroll in this people with moderate to severe acne. You might be more used to seeing IGA 3 and 4. For investigators global assessment. Here we're going to use EGSS, so evaluators global severity score, but it's very similar. A 3 is moderate and a 4 is severe. You can see the inclusion criteria there on the far right. Now, I know this is busy, but this starts with the shock, okay? So what this phase 2 study aimed to do was to show that the triple, using Clinda, adapalene, and benzoyl peroxide together, the triple was better than any of the doubles. And so let's just look at this. So we start with IDP 126, that's Cabtrio, that's the triple. We're going to take it head to head against benzoyl peroxide with adapalene. Keep going to the right versus clindamycin and BPO. Keep going to the right versus clindamycin and adapalene versus vehicle. So we've got a 5-arm study, and 4 of them are active comparators. And you may be used to, like I am, seeing acne studies that enroll 2,000 or so people. And they do that so that we can be sure that we're going to show a big, impressive difference between the arms of the study. So some of us were shocked at the outset that this study enrolled in total 741 people. This means there are about 140 people per arm. And so you look at that and you're like, well, you know, all of these actually work for acne. Are we going to be able to show any kind of a difference between between any of these? Also know that when we are comparing, we're not using other branded products here. We're using the same honeycomb polymeric mesh technology across the board, and we're using the same percentages that are in the triple in each of these doubles, but we're going to do a head-to-head comparison in a 5-arm study. So you'll kind of see as we go through this, we're going to keep these same columns in these same orders. So that's what we're looking at. You see the ends there. Let's go to the box right below the headers. So where it says completed the study, we've got 85 to 90, a little bit more than 90% of people completing the study. And then what we always really want to know is how many people didn't complete the study, and why didn't they? Did they drop out due to an adverse event? So look at discontinued study, and then about halfway down it'll say due to an adverse event. And the numbers are low, 2.7% with IDP 126, 5.3% with the BPO adapalene, 0 with Clinda and BPO. The Clinda and adapalene 2%. So low numbers across the board here. More people drop out of the study just because they're lost to follow-up or they request to be out of the study. Who was in the phase 2s then? And you can see we're keeping these same 5 columns going. So who was in it? They were about 20-year-olds, 19, 20-year-olds, slightly more females than males. Most of the patients were white, around 70% were white, but we had a pretty good representation. 14 to 20% or so were Black in these studies. Asian population was also represented. And when you look at the baseline lesion counts for inflammatory lesions, the baseline was about 40. And for comedones, the baseline was about 50. So I would like to pause when I'm doing a talk like this, because I think we can get numb to these numbers. Did you just hear that? These people have on average 90 lesions on their face. And one of my favorite questions to ask myself and you is how many zits on our face does it take to mess up our day a little bit? And the answer is nowhere close to 90 or 40 or 50. So this is significant acne that we're treating with this topical triple fixed dose combination. When you look at the very bottom, how many of them had moderate acne? It's 80 to 85% with the rest of them having severe. So that's kind of where we're starting with the phase 2 studies. What are we going to be measuring? We want to know how many people go from that EGSS of 3 or 4 all the way down to clear or almost clear. So that's a big jump. It says here on that first bullet point, they make a 2-grade or higher jump. Well, if you start as a 3 or if you start as a 4, you have to make more than a 2-grade jump to be a 0 or a 1. So those people who started out in the severe category in particular, you know, had to make a big jump to get to clear or almost clear. We're also, though, not only are we going to look at success, which is the clear or almost clear, but we're also going to look at lesion count reductions, both inflammatory and non-inflammatory. And assessments will have been done at screening, and then at baseline, and then at weeks 2, 4, 8, and 12. And of course, we will look at safety as well. Okay, so what kind of treatment success do we think we're going to see with this product? And do we think that column 1, Cabtrio, can outperform all of those doubles? And the answer, of course, as you see on this slide, is yes. At week 12, even though there's only 146, 150 people in each arm here, we are able to show that the Cabtrio got 53% of people clear or almost clear at week 12. The other products were not able to do that. And I want you to remember this number, 53% clear or almost clear at week 12. I'll tell you that's a number we're not really used to seeing very much in acne, but I want you to even jot it down if you want to, because we're going to see if we can come close to that number in the phase 3 pivotal trials, because this is still phase 2. This is still phase 2, so small study here. Now, I like how in this deck we're going to go success rate, and then we're going to go into adverse events, and then we're going to look at lesion count reduction. So let's talk about safety and adverse events here. And you'll notice we still have these same columns going. So we have the Cabtrio, and then we have the double, 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 and then vehicle. That first row there says any treatment emergent adverse event. So remember that could be, I broke my leg, I had nasopharyngitis, I had COVID. Okay, so that's all comers. Serious AEs, which is right below it, those numbers are really low, and none of those were related to the study drug. When you look at the severity of these treatment emergent adverse events, now we're back to just all comers. These are not necessarily drug related. Most of them are mild to moderate. Now, when you get to the bottom where it says grade 3 severe assessments, we have kind of done a little switcheroo here. So the top half of this slide is talking about adverse events. And remember, adverse events are asked open-ended of everybody in the study. So you come back into the study for your week 4 visit, and the investigator says, okay, what's happened that I need to know about since the last visit? And they might say, I've had a cold, or they might say, my face has been really dry. Okay, that's an adverse event. But tolerability is assessed on every single patient in the study, and that's what's listed there at the bottom under grade 3 severe assessments. So the investigator looks at every patient and says, are they scaly? And if so, is it mild, moderate, or severe? Do they have erythema? And if so, is it mild, moderate, or severe? And then you ask the patient, are you itchy? Do you have burning or stinging? And if so, the subject tells you if it's mild, moderate, or severe. So when it comes to grade 3 severe assessments, there weren't very many. You know, we've got 141 people. 6 of them had some severe burning, and 3 had severe stinging. And yeah, it's a little bit hard to tell the difference between burning and stinging, but all in all, those numbers were still really low when it came to tolerability. Okay, let's look at some clinical pictures. This is one of the best in the whole deck. Okay, now I want you to think, would my patients be pretty pumped at week 4 on Cabtrio? So this is a 14-year-old Asian male. This is baseline, and here comes week 4. So at baseline, they're a moderate, EGSS of moderate. And here's week 4. And, you know, in most clinics, we're not seeing them back until maybe closer to week 8, week 6 or week 8. And that's a pretty darn significant improvement. And then at week 12, the investigator here rated them as a clear, an EGSS of clear. So they went three notches down from a 3 to a 0. How about lesion count reduction? So we're going to look at inflammatory first, and then we'll look at non-inflammatory. And inflammatory usually is a little faster to come down. Our primary endpoint is week 12, so we'll look at that first. This is still phase 2. This is still small numbers, but comparing itself against the doubles and the triple wins with 76.4% reduction of inflammatory lesions at week 12. And you can see the fast onset. I'm going to wait and talk more about that when we get to the phase 3 pivotal trials. But remember the number 50% for treatment success, but let's remember 70% for lesion count reduction, and see if we can achieve this again when we get to the pivotal trials. This is comedones, okay? They are usually slower. They drag behind a little bit, but we're still achieving more than 70% reduction in non-inflammatory lesions at week 12 as well. And again, if you just back up and kind of take a look at that curve, even as early as week 2, we're seeing some nice improvements there. And we'll look at another. This is a 13-year-old Black female, EGSS of moderate at baseline. Okay, so here she is at baseline, and then week 4. So pretty rapid onset of action too. That kind of goes along with what we see on that curve of lesion count reduction. And then week 8, and then at week 12. And here the investigator said almost clear. So this is still a treatment success. When you get to 0 or 1, your treatment success. So these would be included in that 53% number that we saw. Okay, that was all phase 2. Now let's go to phase 3. And a lot of this will probably look kind of similar to you, but what numbers are we're gonna remember? We're gonna remember 50% for treatment success and 70% for lesion count reductions. And let's just see if these studies are gonna mirror those, are gonna, show us similar data. So here we are in the phase 3 trials. Again, 2, they're going to be sister studies side by side. Now the only comparator, though, it's not those doubles anymore. It's the active compared to the vehicle. So 2 phase 3 multi-center randomized double-blind parallel group vehicle controlled studies down to the age of 9. But remember, we're FDA approved 12 and up. Moderate to severe acne, again, an EGSS of 3 or 4. And then on the far right, you see the inclusion criteria for facial lesions. And this is the study. Again, this is not a huge number. Together, the 2 studies together, 363 people. So study 1 has 183, study 2 has 180. We did randomize 2 to 1 here, so twice as many people are exposed to the active as they are the vehicle. And I think that's good for a lot of reasons. It's good as we assess safety. We want more people exposed to the product. It's also good because the product seems to work very nicely, and we want people who are in the study to get an effect from that. But you can see 122 people in IDP 126, which is Cabtrio, versus 61 in vehicle, and similarly in study 2. But remember that, like when you get to an adverse event, then you want to be comparing them by looking at percentages and not numbers, because the denominator is going to be different there. But how many people completed the study? Again, around 90%. And then the opposite, of course, is who discontinued the study, but due to an adverse event was really low. In study 1, that was 1.6%. In study 2, you can see it was 2.5%. Most people, again, just were lost to follow up, or they requested to be withdrawn from the study. What are our endpoints here? They're similar to phase 2. We want to know what's the success rate. How many people get all the way down to a 0 or a 1? And we want to know lesion count reduction, inflammatory and non-inflammatory lesion count reduction. And the actual endpoint here is looking at absolute changes, not looking at percentage as the primary endpoint. And we're going to help you out a little bit and show you percentages because it's easier to think of the numbers like that. Assessments, again, were conducted at screening, baseline, weeks 2, 4, 8, and 12. The secondary endpoints are percent changes, also the percentage of people who achieved a 2-grade improvement. So that would be like you did start as a 4 and you went down to a 2, so you went down to mild, you just didn't meet all the way down to a 0 or a 1. So that was included in the phase 3 too. Also, we're gonna look briefly at treatment compliance and then safety and tolerability, of course. Skincare. So in the phase 3, people were only to use investigator-approved non-medicated cleansers, moisturizers, and sunscreens. It was okay to use makeup. It was supposed to be non-comedogenic. They were asked to not wear makeup when they came in for the study visits. And they were given instructions on how to wash their face, how to dry their face, and then how to put that little pea-size amount onto 6 areas of the face, ensuring that they were treating the entire face. So it was like 2 on the forehead, the 2 cheeks, 1 on the chin, 1 on the nose. I think that was 6. This is our baseline demographics here again, about 19 or 20 years of age. Most slightly more female in this one as well. Again, predominantly white, but a nice representation of Black or African American skin, Asian, and other. The baseline inflammatory lesion count here around 37, 38. The non-inflammatory lesion count, let's see, 45 to 50 in that range. Most people here again had moderate, so they started out as an EGSS of 3, and some did have severe. It differed depending on which arm of the study you were in. Now look for a minute with me at those bottom 3 lines. I think this is interesting because we even talked about in the important safety information, I know that many of us just do this in clinic in general, we said that if people had irritation, they could reduce the frequency. or, you know, they could use a moisturizer. So we just talked about skincare. Do we have any idea how much people actually used the drug in the studies? Well, if you look at this, at least, you know, according to their reports, the mean number of days that they applied this, and if it was a 12-week study, that would have been, well, I'm going to say 90 days. It's not exactly that. If you look at this, they used it 81 days, 84 days, 82 days. So if you look right under that, expected application applied, they were getting it on about 97% of the time, 95% of the time. So there was some pretty consistent applications here. How did we measure compliance, which is the very last line on here? That would have been people who said that they missed no more than 5 consecutive days. Okay, so that one we're just having to trust them. But it was also a measure of, let's weigh the tube, and are they using between 80 and 120% of the expected amount they would have used? And compliance was good. You can see the numbers all in the 90s there. So we have an idea, at least, that people were really putting this stuff on. We have that idea too because it worked, but I think that gives us even a little bit of help when we look at potential adverse events and tolerability. Okay, what was our treatment success in phase 2? 53%. And here we are in phase 3, and in both studies, side by side, they look a lot alike. We're getting a treatment success at week 12 of 50% in study 1 and 51% in study 2. And you can see the p-value right up under the study 1, study 2 heading. This is statistically significant. And that's a big number for treatment success with one product. Okay, we're going to bounce back over to adverse events and tolerability. This one is adverse events. Okay, so even though all of these sound kind of like things you would do for tolerability, these would have been voluntarily reported in. Okay, so how many people came in and said, I've got some burning and stinging throughout the study? It was 13.6% of people on Cabtreo. That was the biggest number here. And I never brush these under the rug at all. You know, that's real. This drug has a retinoid in it. This was a 12-week study, so some people did have burning and stinging. We know how to manage that. We also know that we can educate people up front on how to use this product. Erythema, 4.5%, dryness, 4.1%, irritation, 2.1%, exfoliation, 1.7%, and dermatitis, 1.2%. And you can just compare it to the vehicle right beside it. Those are all higher than the vehicle. Now, it's a little bit different when we look at tolerability. I'm going to show you 2 slides on tolerability. So this now, everyone is being assessed on this one, and it's erythema, burning, scaling, itching, and stinging. This is at the end of the week 12. Okay, so most of us would realize, and it even says it over on the second bullet to the left. Let's see what that says. Local tolerability scores increased during the first 2 weeks of treatment and decreased thereafter. Okay, so week 12 is kind of a sweet spot. And when we look at this, there still is some erythema. Let's look at erythema though in Cabtreo. Out of the people who have it, most of it is mild. Some is moderate, very little is severe. But look at vehicle. It looks almost the same at week 12, 22 point. You know, people with acne have some erythema. And so those two aren't that different. When you look at burning, this one is a little different between the two, but this number is pretty low. So it's not a big number to begin with, and most of it is mild. Scaling, these numbers are pretty low, but all of this is at week 12. The next slide is going to show you the maximum score throughout the week 12. So let's see what that looks like. So here we are now. This is maximum during treatment. There are people who are going to have erythema, and this is more than vehicle. And you can see the numbers there. By far, most of it's mild to moderate. And again, we got the same second bullet over there. I would imagine, I don't have numbers to back it up in this slide, I would imagine most of this was very early, at week 2, for example. And so we see burning, we see scaling. Again, most of it mild to moderate, itching, mild to moderate, and stinging, mild to moderate. But this is the maximum during treatment. All right, let's look at some more clinical examples here. This is a 14-year-old Asian female. Now I'm going to go ahead and just tell you, this person does not meet the treatment success. Okay, so let's watch and see. We see this person at baseline, and let's just say in our clinic, this time we're going to see her back at week 4. Okay, this one to me is not quite as fast. And then week 8, now we're really starting to see the improvement. And then at week 12, that's a lot better. this person, we always say this when we look at these, this person would be happy, and we wouldn't say, oh, you know what, it's week 12 and you're only mild, so I'm going to change you to something else. We wouldn't do that. This is somebody who's been on a slope of improvement and they're a lot better. I think they probably need more time, but they've gone from a 4 to a 2. So when we talk about a 50% success rate, realize that this person wasn't in that. Okay, they had a 2-grade improvement, but they wouldn't be in that 50 or 51% success rate. Okay, how about lesion count reductions? Let's start with inflammatory. And now we have study 1 and study 2 side by side. Remember from the phase 2, it was a 70%, more than 70% reduction. Did we do that? Well, we did better than that. In study 2, we've got 80% reduction of inflammatory lesions at week 12. In study 1, 76% reduction at week 12. And here's where I want to slide back on the graph. Let's look at week 4. We are getting more than 50% improvement at week 4, close to 60% improvement at week 4 in study 2. This is rapid. At week 6, we're getting, at week 8, we're getting, 63, 70% reduction. So fast and certainly statistically superior to the vehicle. How about non-inflammatory? Here we're still beating the 70%. So even with comedones, which can be slower, at the week 4, we're not quite to 50, but we're at 45, 46% reduction in comedonal lesions. And then, at week 12, 72.7% in study 1 and 73.3 in study 2. And here's a couple more pictures. Another person who starts out as severe, and this is a 14-year-old white female. Let's see her back in 4 weeks and see what she looks like. That's better. And let's see her at week 8. That's better. And let's see her at week 12. So lots better again here. We're not going to throw in the towel, and yet she is mild. So she made a 2-grade jump, but she's not in the success group. So these are some of the people who would be in the failure group. And yet, if you saw this person in clinic, we wouldn't throw in the towel. Okay, this is a nice one, 18-year-old Hispanic male. We look at this, and this is pretty significant acne. They called this a moderate. I might have even been tempted to call this one a severe to begin with. But let's see this person at week 4, excuse me, and at week 8, and then at week 12. And so they make it all the way down to mild as well. So, we're showing you several in a row here who have 2-grade improvement, but are not in that group of people who are clear or almost clear, or who are called a treatment success. How about we see a success? Let's watch one that's a success here. So this one starts as a moderate. This is an 18-year-old white male. Week 4, week 8, and at week 12, almost clear. So this one started as a moderate, so made a 2-grade jump here too, but that pushes him into almost clear. So that one is part of the success. Okay, so do we have any information from the patients? I do always like to remind myself too that we're not treating acne, we're treating people with acne. And it's one thing to count bumps, but we do need to have those patient-reported outcomes. We do need to hear from the patient, is this impacting your life in a positive way? And so our scales to do that are not perfect, but this is using the acne-specific quality of life questionnaire. So individuals would have been given this questionnaire before treatment and then again at the end of the study. So this is looking at improvement at the end of the study. And when you improve in each of these, like there are questions about your social engagement, there are questions about acne symptoms. So when you improve in each one of these, the number, your score on that quality of life test is going to go up. And so it looks like at the end of the study, the score went up in the vehicle and it went up in CABTRIA. So heck, everybody, their life improved through the study. And it's significant if the difference between those two is 2 or more. And in all of these, it's at least 2. And so there was a difference when it came to a quality of life measure in patients who were treated with CABTRIO. All right, we're coming to a close here, but we've got a little more data. Okay, this was just a really nice surprise. Okay, so this, nobody at Ortho is responsible for this. Okay, this was just done by somebody else. It was a meta-analysis, and those come with their own issues. This is not a head-to-head study, but the authors of this study pooled together different acne studies, and based on that, they used total lesion count to stack these different treatments up to look to see which ones seem to have the best results. And if you'll look right above the graph, you'll see the black dot says oral treatments, the red says topical treatments, and then I think that's a dark green that says combined oral and topical treatments. So we're not just looking at single drugs, we're looking at treatment approaches. And when they stacked all of these up, they found that there was one drug that worked better than the rest, and it was isotretinoin orally. That doesn't surprise us. In fact, that kind of makes me believe this even more. But in the number 2 position was Cabtrio, was this new product that we have. And they were able, what they were looking at then, they didn't have all the phase 3 studies yet, but they were looking at the phase 2 data where we had that good lesion count reduction. So I do think that's interesting to kind of just stack this up. It's not perfect. It's not a head-to-head study, but this was independent of ortho. And I think that's just really interesting. Okay, in summary then, let's talk about a couple of things. Has anybody heard about benzene in the news, or benzoyl peroxide? So I think all of us have. I do want you to just know that would be a whole nother topic. We're not going to talk about that tonight. But before that came up, before that ever came up, this product was already being manufactured, distributed into the pharmacies using cold chain. And that means that this is kept at a refrigerated condition between 36 to 46 degrees Fahrenheit throughout this whole process until it is dispensed to the patient at the pharmacy. That was not a reactionary move. This was already being done. Now, if you're the patient, once you dispense it, I'm probably talking to my patients more about this now. We're telling them things like, don't freeze this, but store it either at room temperature, as long as you're at or below 77 degrees Fahrenheit. Or I tell my patients, and that's not part of this, but you could put it in the refrigerator if that's something that's convenient for you. But most importantly, keep it away from heat. Store the pump upright. Don't ask me why we store it upright, because I don't know the answer to that one. And then we are starting to watch expiration dates a little more closely now, and the expiration on a dispensed Cabtrio is going to be 10 weeks. So in summary with this, we looked at really impressive efficacy. We looked at clearance rates that were more than 50%, and that was in the phase 2 and both of the phase 3 studies. That was at week 12. We also saw that the treatment emergent adverse events were mostly mild to moderate. This was also a well-tolerated product. And then those bottom 2 sections there, I think there's simplicity to this drug as well. So it's designed without irritating ingredients. There's no alcohol, surfactants, or preservatives. And then maybe most importantly for our patients, we get a lot done with one script, one pump, and once a day. And I think that's something impactful to my patients. I don't normally do this slide, but I will tonight. Access, of course, is always the name of the game. $0 copay for most eligible patients whose commercial insurance covers Cabtrio and when the deductible is met. For those who the commercial insurance does not cover Cabtrio, $75 copay for the first and any eligible refills. Cabtrio is not the only game in town. So Cabtrio is for patients with acne vulgaris age 12 and older who need a triple combo topical therapy in a single script. But don't forget Araslo. So Araslo was FDA approved in 2019. It is indicated down to the age of 9 and older, for those who need a topical retinoid, and that's Araslo, which is tazarotene lotion 0.045%. And because I just said the word Araslo, we get to go through one page of its important safety information, and then we'll be done. So it is indicated down to the age of 9 for individuals with acne. It's for topical use only. It is contraindicated during pregnancy due to the potential harm to the fetus. Females of childbearing potential should be warned of that. And the package insert does still say a negative result for a pregnancy test should be obtained within 2 weeks prior to Araslo lotion therapy. Skin irritation can be an issue with this one as well. In particular, application site pain, dryness, exfoliation, erythema, and pruritus. But just like with the others, if we need to, we can pull back the frequency of dosing. We can use skincare to help us through that. We do want to be careful with sun as well here and tell people to use good sun protective measures. And also be careful if they're on or using any other drugs that maybe are photosensitizers, whether that's topical or oral. Weather extremes such as wind or cold weather may make some of the irritation issues worse. And then the most common adverse reactions in the clinical trials with Eraslo, those that happened at a rate of 1 person or more and greater than the vehicle, were application site pain, dryness, exfoliation, erythema, and pruritus. And with anything we talked about tonight, if you have any suspected adverse reactions, please do report them. And you can see the number for Bausch Health there at the bottom, and also a 1-800 number for FDA. And I think that's got us covered. So thank you so much for your attention on that. I think you can see maybe why we were all excited to have the first triple fixed dose combination for our acne patients.
Thank you so much, Dr. Harper, for that fantastic talk and discussion on acne, but also this amazing topical that we have now in our armamentarium. I'm going to open the chat box for any questions. Anyone in attendance, please submit your questions on the right-hand side. We will wait momentarily to see if there's any questions coming in the chat box as well. Dr. Harper, a question that is commonly asked, if you do get those very mild and rare symptoms of irritation or itch or burning, and we know that's very, temporally related to starting the CAB trio in the first 2 weeks, what are some tips or tricks that you recommend to your patients to weather the storm, so to speak?
Well, I kind of use CAB-Trio like I've used most of my other topicals, and especially the ones that have retinoids in them. Maybe I'm kind of a chicken because I usually start out like Monday, Wednesday, Friday for the first couple of weeks, and then I have people titrate it up. And if you look at the studies, they didn't do that. So I probably could be more bold with that. But that's one thing that I think you can do. And then certainly part of treating acne effectively is not just writing the right prescription. It is also taking over skincare and making sure that they're not using other products that are irritating, kind of like we saw in the phase 3 trial. They don't need to be using a medicated cleanser. We're going to give them the medicated part. So taking over skincare, making sure that they're using a mild cleanser, maybe even a cleanser that's got a little moisturizing capacity to it, and using a good moisturizer with the product. But I don't mind to go every other day for a while.
Absolutely, and I do the same. I'm kind of a chicken like that too, but slow and steady wins the race. Thank you so much, Dr. Harper. If we don't have any questions, this will conclude our webinar for CAB Trio. And I'm just going to go on to the next slide. Thank you, Ortho Dermatologics, again for sponsoring this wonderful webinar and educational series. And just as a plug, please stay up to date again via Instagram, LinkedIn, or Facebook at the IDEF Derm handles. And then we'll have the pleasure on Monday, August 19th next week, having Dr. Linda Steingold discussing chronic hand eczema. And thank you again, everyone, for attending today. Have a wonderful evening. Bye-bye.
Good night.